did you decide on empirical antibiotics in when it comes to pneumonia, and whether you want to give gram-positive cover or not? That's the question that comes in. So, these may not be absolutely with the guidelines, but this is something that will help you to do. We don't sit here just to complete an exam. We also sit here to understand how to treat patients as we go ahead in critical care, isn't it? That's the real thing. So when we look at MRSA treatment guidelines when it comes to pneumonia, there are 16 guidelines. Okay, there are 16 guidelines. And when I said gram-positive infection when I put that search term on PubMed, I got 1,563 studies. So it's not easy when somebody is asking this question, should I give gram-positive cover? I mean, this question of gram is such a broad-based question that I can't answer that in one go. So it's so much of data is there on the background that it is impossible for you to tell what to do. That is why guidelines are always a good starting point. That's why guidelines are a good starting point, because what happens with the guideline is, you have people who are sitting across a table, spending time over a period, spending their valued time, and then synthesizing the guidelines and then giving you a kind of a take-home message. Because today what happens is, if you take one guideline, read another guideline, you get one data, another data, third data, you'll find everything confusing because there's so much of data. And believe me, on an average day, there may be more than 200 papers on critical care coming out in one particular topic. That's the amount of data that is coming out every day. It's impossible for us, unless we have an artificial intelligence wired brain, to understand what is happening. So what I've done here is, I've looked at the data set in gram-positive infections and then come out with some ways that I would love to treat my patients, and I was doing this till a while ago. Okay, and I'll show you how to do this. Okay, so what we are trying to do, you know who this is? Nostradamus. Nostradamus was the person who actually looked into the future. So when you look at empirical antibiotics, we are looking at how in the future can I predict that this patient has got gram-positive infection. The entire thinking is your clinical knowledge and your entire synthesized evidence is based to understand whether in the future this patient is going to have gram-positive infections or not. That's the entire thing about gram-positive infections. Okay, so do you see a risk or don't you see a risk of MRSA infection? That's the question we have to answer. Okay, do you see a risk or don't you see a risk of MRSA infection? And that's the reason that today will discuss about risk stratification for gram-positive infections. Okay, what I have done in this is, I have actually you put RCTs, some reviews, some observational studies, cohort studies, and then I have come to a meaningful summary. This is exactly what I have done over here. Okay, so you will see the summary, and in this approach, we have to think of what to do with in-hospital cases, SSTI, community-acquired pneumonia, infective endocarditis, febrile neutropenia. In this journey, we will actually stop at each of these places and see how this works. Okay, the whens and whys as to how to do this. Okay, so the first time in 2013-14, I actually looked at the data, okay, of the infections that are there in our hospital. When I say isolates, it means whatever is there over here in the microbiology, what is coming out, we took all of those out. And 2013-2014, when we looked and analyzed what we are seeing, we saw a good proportion of gram-positive infections, a very good proportion of gram-positive infections, a very small and a larger proportion of gram-negative. 50% of them were gram-negative infections. 50% is a big number. And most of these patients were on teicoplanin, linezolid, daptomycin and vancomycin is what it looks like. And there was a huge amount of empirical use of gram-positive infections. In 2013-2014, every patient at least 75% of patients who got admitted with a lung infection got either teicoplanin or vancomycin. Alright, a good number of patients of SSTI, that is skin and soft tissue infections, they also got it. Some were non-specific, they don't know where it is, so they give an empirical antibiotic combination, and some got for abdomen. Alright, and among the specimens that they received, the maximum isolates that they got for gram-positive infections were from SSTI, skin and soft tissue infections. They had the maximum amount of isolates for gram-positive. So it's very clear that there is a large amount of gram-positive infections in our hospital. And that is why is that so? Because we are a tertiary care center for diabetic foot infections. Our maximum number of patients that we had was diabetic foot infections. This is what I thought. 99% of our patients come from other hospitals. This is what I thought, okay? This is what I think after looking at this data, that why we have so much of gram-positive and why we have so much of MRSA. I thought the moral of the story is we have lots of MRSA. This is what I thought when I saw just the isolates of 1 year. Right? So then, in fact, I thought we should be having lots of MRSA. Then I started correcting myself, is this the right thing? These are isolates. So in these isolates, I'm seeing this. Is this the answer? So that is why the routine SSTI empirical antibiotics at that time, 2013-14, was we had actually added cephalosporin sulbactam, that is Bagnex 4, plus the presence of either Tico or Vanco or linezolid. We had put this as our antibiotic of choice. We just now discussed as to why we would want to use these antibiotics. But then what happened, the subsequent year I decided, let me study this any which ways. So I went back and I really studied it very, very closely. And when I studied it very closely, I found that we had one isolate in 44% of patients, two isolates in 41%, and three isolates in 11.7%. And 26.9% of the isolates here, 26.9% of the isolates were Staphylococcus aureus, but a good proportion were gram-negative also. A good proportion of gram-negative. So when you look at SSTI, initial my thinking was gram-positive बहुत ज़्यादा है, but it's not like that. Gram-positive is almost equivalent to gram-negative. In fact, gram-negative is slightly more high when you look at the numbers that are there. Only the most predominant organism that you have among everyone, gram-positive and gram-negative, seems to be Staph aureus. That is why it is 26.9%. Okay, 68% of them were still gram-negative. Okay, 68% was still gram-negative. All right, and only 22% actually of the whole population was looking at gram-positive, and 70% of them were susceptible to vancomycin. So we were not leading with Visa or MRSA and things like that. 70% of them were still susceptible to vancomycin, what it appears. So then I looked at why are we doing it empirically like this. So I looked at stool. Many times it so happens that abdominal infections, we don't know, we think it's abdomen, it's not the lung, it's not the skin, it's maybe the abdomen. Let me start meropenem teicoplanin. Empirically, So then when I went and found, I did culture swabs of all patients that are coming from the abdomen. And what we found there, 0% of MRSA in stool samples. I took stools of all patients in our ICU, in our hospital, and I cultured them. When I cultured them, I didn't find a single MRSA. So in short, MRSA does not exist only. In fact, I got 54% CRE, but it was completely empty, no MRSA at all. Okay, so MRSA in the stool is not there. Plain language inferences were what? Numbers are small. We don't need an MRSA cover often, not at all in GIT. Not at all. If it's GIT, I don't require MRSA cover because it is not there in the GI tract. Okay, let's escalate if required. I mean, we can wait. And empirically, we don't need Vanco, teicoplanin, daptone, linezolid is what my plain language summary was after seeing my data. Now, what happens in oncology? In oncology, what happens is the moment the patient is shifted to the ICU, we immediately see a picture like this. There's a small pneumonic patch on the right side, and the moment this happens, he says, let's give him teicoplanin and linezolid. This is what occurs. So let's look at the guidelines. Okay, what are guidelines? When you see evidence-based pyramid, this is the evidence-based pyramid. All of us should know this. The topmost is evidence-based guidelines and textbooks that come as they're in summaries. Okay, then comes as systematic reviews and RCTs. This is how the evidence-based pyramid is all about. And evidence-based guidelines and textbooks are something that we normally refer to. None of us look at multiple RCTs. We want information quickly and fast and easy. So you look at guidelines. So what are guidelines? Guidelines are people sitting across a table, learned people sitting across a table, discussing over a period of time and giving you an answer. They are experts basically, and that's the reason that we like to look at guidelines. We love it because of the fact that we are getting information at our fingertips without even you needing to synthesize evidence. So they do a lot of work to actually give us the answer. So what do the guidelines now say for MRSA pneumonia? This is the question. What do the guidelines say for MRSA pneumonia? Okay, now we get into the exact meat of the topic as to what are the guidelines. So the guidelines that says of the CD clinical practice IDSA, what they say is for MRSA, this is the topic for today, for in pneumonia and MRSA, hospitalized patients with severe community acquired pneumonia defined by any one of the following: requirement of intensive care unit or necrotizing cavitary infiltrates. Now you know why necrotizing cavitary infiltrates, or empyema, or therapy for MRSA is recommended pending sputum or blood culture results. That means every patient that enters into intensive care unit with a pneumonia will require MRSA cover. So that's not what we do. It's something that is quite horrible. If you have to give every patient a Vanco, a Tico, a linezolid or a daptomycin, I just told you the story of what happens over a period of last 20 years. I'm seeing what is happening. What are we going to head up to? This is what IDSA recommended. Now let's do one thing. That also pending sputum and blood culture results. Okay. Now that is A3. That is there. So that's why when you read a guideline, don't just read the guideline. Look at the level of evidence. So the level of evidence here is A3. Now, what is A3? A is good evidence to support a recommendation for or against use. But what is 3? evidence from opinions of respected authorities based on clinical experience, descriptive studies, or reports of expert committees. It's not really a randomized controlled trial that has given you this answer. Okay, that's why it's an A3 recommendation. Okay, it's not if it was 1A, it's a different situation. It is an A3 recommendation, right? So it's not a great recommendation. Now let's look at the same IDSA guidelines, not for MRSA but for community acquired pneumonia. Okay, now what I'm going back to IDSA, same IDSA, and a different year, but looking at community acquired pneumonia. So what should this say actually? It should say if a patient is coming into the intensive care unit, patient should be given MRSA cover. This is what it should say. Let's see what it says. Okay, it says it has to be given only to those patients who have specific group of individuals, for example necrotizing or cavitatory pneumonia. Suddenly the guideline has changed. Same IDSA, two different. That's why, because there are experts, different experts sitting for this guideline. So it is community acquired pneumonia. So that means it's confusing. What would I do? I mean, now today if the patient comes into ICU, there is no necrotizing pneumonia, there is no cavity, I will not give MRSA coverage. Just before this we discussed, patient को अगर ICU admission का जरूरत है, we put them on MRSA cover. So that's the problem when you look at guidelines. Okay, that's why as doctors working in intensive care unit, you need to set what you are going to do. Okay, so that's why when you see the end of a guideline, any guideline you read now, you will have this written. It is important to realize that guidelines cannot always account for individual variation among patients. They are not intended to supplant physician judgment with respect to particular patients or special clinical situation. IDSA considers adherence to guidelines to be voluntary. मतलब they are telling you तुमको करना तो तुम करो. With the ultimate determination regarding their application to be made by the physician in the light of each patient's individual circumstances. That means you take the guidelines as a good starting point, but don't take that as your rule. Guidelines are not rules. Guidelines are directions. Right? So let's go to a case. Okay, let's go to a case. You have a case of 70-year-old diabetic female with dementia, admitted with features of pneumonia. So what would be an antibiotic? Would you empirically give MRSA cover here? Would you give MRSA cover here? So Ashok, you have been treating patients in the ICU. You have a 70-year-old demented patient who basically comes to you admitted with features of pneumonia. Okay, would you give teicoplanin here? This is a clear community acquired pneumonia coming from outside. It's a 70-year-old elderly, dementia, has got comorbidities, diabetic and dementia. Would you give MRSA cover here? And on what basis are you going to give this? If you want to give it?
Yes, sir.
You will want to give MRSA.
70-year-old with diabetes.
But this is community acquired pneumonia. How are you considering MRSA? We are not talking of streptococcus pneumonia. We are talking of MRSA. How are you suspecting patient has got MRSA here? You are understanding the question? We are not talking of streptococcus. We are talking of MRSA. Are you suspecting MRSA in this patient? For that matter, in this hospital, in this ICU, 99% of what you are saying would be then requiring MRSA cover. 99%, isn't it? Like if you count now all the patients in the ICU,
More than 70 diabetic.
everybody is 70 and diabetic. Everyone requires MRSA cover. Are we on MRSA cover in all these patients? No. So tell me, how do you determine that? So you say you will still want to give or no now? After listening to this, what do you feel? Who wants to give? Who doesn't want? Who doesn't want to give?
No.
You don't want to give. You don't want to give. You don't want to give. Now suddenly you changed your entire thinking. Okay, let's go one more. So yes or no and maybe is going on now with everyone. Okay, so let's do one thing. Hours later, I sent a gram stain, which we normally do, and gram stain doesn't take more than an hour to see. Now you see a gram stain, it shows gram positive cocaine clusters. Would you give? Would you give now? This is what comes. I am telling you what practically happens. Okay, this is practically. You get gram stain, it comes gram positive cocaine clusters. Would you give MRSA cover?
But it should be
Gram
sensitive.
No, I am saying gram positive. You are saying we are in empirical. Sensitivity तो पहुंचे नहीं, हम लोग empirical में हैं. हम लोग क्या सोच रहे हैं? Before antibiotic sensitivity comes in, do I give it or not? Cluster में है, इसलिए you want to give it. Anyone else?
Plus 70-year-old is in high risk also. Even if it is community acquired, plus we don't know whether she's come from some nursery.
But why? I'm telling you, she's not come from nursery, come from home.
She's come from home.
Ah.
She's still in high risk where there.
You have MRSA at your house. Your mother and father has MRSA.
No.
That means you have MRSA in your house. If you're thinking like this, you have MRSA in your house, isn't it? So you give me an answer. I'm okay with whatever you say. And we
Depending
can.
on pneumonia, CVT score, patient require ventilation.
नहीं, patient doesn't require ventilation. Patient has come to you. Patient को तुमने ग्राम स्टेन किया है. ग्राम स्टेन तुमने देखा है.
पॉजिटिव तो
हाँ?
दे दूंगा मेरा।
पॉसिबिलिटी को देना है.
अभी मतलब इतना ग्राम से में आ गया उतना।
ओके ठीक है. So again yes no maybe चल रहा है. हाँ यहाँ पर. So now what I will do is day 3 X-ray is now showing non-necrotizing, non-cavitatory. Non-necrotizing, non-cavitatory is what we normally see, non-necrotizing, non-cavitatory, but MRSA is grown and is clinically improving. Till now you have not started. You decided to put the patient on monoseph. Patient is on monoseph and azithromycin, and now you have found this picture. Day 3 X-ray is actually showing a pneumonia. It is showing a pneumonia, but the patient has grown MRSA from that clusters what you had over here, cocci. He has grown MRSA. Patient is clinically doing well. Do I change the antibiotic? Would you empirically give MRSA cover now at day 3? Day 1 पे देना चाहिए था.
Now she's anyways improving.
Now she anyways improving, so not to give. But we know that if you don't treat it well, patient can have relapse and bacteremia. We discussed all these things.
But she's having some non-necrotizing also, which is community acquired.
But you have MRSA.
And I will
So now we can.
And he's on ceftriaxone, so not on cephazolin.
in long term also sir like so by add up like endocarditis and also we have to cover that.
But it is not bacteremia. Endocarditis and all comes when there is bacteremia, complicated and uncomplicated bacteremia.
So yeah,
for
we can
after-
cover with the 70 course of. So like,
But then why aren't we increasing the risk?
So initially-
So the question is this an infection that is causing pneumonia inside the lung? Is this an MRSA infection which is causing pneumonia in the lung? So let's look at evidence now. Okay, it's a yes, no, maybe till now. So I'll try to solve this for you now and try to give you few things that you must know. Few things that you must know on MRSA pneumonia. It is overdiagnosed because it is very easy to culture Staph aureus. It's not as easy. So Staph aureus, तुमको next day you get the culture Staph aureus आया है. When you see Pseudomonas or Klebsiella 4 days, 3 days के बाद उसका Klebsiella आया है. चल मैं antibiotic sensitivity करके लेता हूँ. You seen that, right? Staph aureus ठक करके पता चल जाता है तुम लोगों को because it's easy to culture. It cultures very quickly. Okay, and it's very rarely a true pathogen. When I say pathogen means it is gone into your lung, it has created that pneumonia, and that is what brought you to the hospital. That is the meaning of pathogen. Anything other than that is a colonizer. Anything other than that is colonizer. If that particular organism has gone into your lung, created the pneumonia, and then you have treated that, that is a true pathogen. Okay. Otherwise, everything else is a colonizer. Clear? Alright. So now, this is an original article that was done with gerontology in old age. Now, our thinking was old age, right? So they looked at old age group. 78.7 was the average age of these patients. Okay, average age, and they were classified into true pathogens and false pathogens. Means they did cultures and they found out that MRSA RI, but he didn't have pneumonia, or MRSA RI and he had pneumonia from the same area, and they call them as true pathogens and false pathogens. And what they found was they found that a total out of the total 93 patients classified to true was only 16, whereas those that had false were 77 in the whole group. You understand? So when you get culture, it doesn't mean that the patient has got MRSA pneumonia, especially in these older age groups. They may have MRSA, but it may not be the pathogen causing the pneumonia. Are you understanding this? Are you understanding this? Is first thing, you must remember this. Okay, I'm just trying to put some things in your head so that you understand how clinically I'm listening, I'm thinking. Okay, so clinically I'm thinking he's an old man, he may have MRSA, but that could be a false pathogen, it might be just there inside. Right? Huh? Alright. So there, in another study that was done, what they did find was 66.7% of patients were possibly considered to have MRSA, but out of that, only 33.3% it was actually causative. 50% of people whom we considered as MRSA were actually not MRSA pneumonia. The true pathogen is seen only 50% of those. समझ में आ रहा है? Huh? Clear? So the incidence seems to be low, and the sensitivity is very high for diagnostic tests. But we are getting that MRSA quickly. That is why it is looking every time it is coming up. So then what to do, treat or not to treat? That is again the question that comes to you. What to do with this kid? Do we treat or not treat? So the strategy. So what I would consider as a strategy here would be something like this. So it has to be a combination. It has to be a combination. Okay, so it's a combination which says a combination of a throat culture, a short score, a sputum gram stain, a procalcitonin, and a clinical judgment. So let me take each of these. I'll take you to each of these to understand each of those. Okay. So the first thing is short score. All of us sitting in this room should know when it comes to community acquired pneumonia what is a short score. A short score is a very simple thing. It is there on MD Calc. In MD Calc, if you put it, you will get this. It has got a couple of points. Okay, and it's down here. You see the short score here. MRSA got many scores. So when you put MRSA, you get the short score down here. Okay, that's the MRSA score. MRSA in patients with pneumonia, right? And when you put that score, what they found is that if you get the score is all the same things only. In the nursing home, there is some set of things that are there. That those 5-6 things are there. So all these things comes in that. When the short score is high, you can actually think that those patients who had a high short score would probably be having MRSA as a true pathogen. Okay. So to validate that short score, what did they do? They did this data. So they looked at 62 US hospitals, and retrospectively put the short score. Retrospectively, they put the short score. You notice what they did? They looked at 62 US hospitals and retrospectively put the short score to it. And when they put the short score, found out those patients who had MRSA versus those who didn't have, they found that they were able to actually figure out that a good number could be actually predicted with a short score. Okay, and this and similarly, the same short score. This is the short score that they looked at: comorbid illness, severity of illness, prior hospital, age less than 30, more than 79, IV intensive care unit admission, cerebrovascular dementia, female with diabetes. All this comes in the short score with points. When they did this in 62 US hospitals, they found that those who had 0 to 1 point, okay, had a very low risk of getting MRSA pneumonia, whereas those who were 6 to 10 points had a high risk of being into the MRSA pneumonia category. 35% plus chances of being into positive for MRSA pneumonia. So now you have one starting point. You can look at the short score, look at it. If the points are more than 6, maybe he may be having pneumonia, but importantly, if the score is very low, he does not have MRSA pneumonia. Okay, above 6, maybe 35%. Okay, but in the event that the short score is very low, then the chances of him or her having MRSA pneumonia is highly unlikely. This is in category for MRSA pneumonia. Clear on this? So after the short score, if it is 0 to 1, they are highly unlikely. Medium, not very certain. 6 to 10, maybe there is a chance. Okay. So the people might say this is a retrospective database. Whenever you look at a study, you have to analyze a study very skeptically. Okay, so I'm looking, this is a retrospective database, so maybe it's not prospective. Normal, good evidence-based summaries are normally prospectively controlled. Okay, it is every patient of pneumonia was not cultured. Obviously, it's like a database. No, it's not something that you do. Not evaluated for co-infections, whether they were co-infected with influenza or something like that. Because influenza has got a higher chance of MRSA pneumonia. And all population data on IV antibody was not captured. So there are some problems with this study, but of course this is a very large database, but there were problems. But it at least tells me one thing, that in the low category, I have a very high chance of identifying those patients in which I don't require to give MRSA pneumonia what it appears. I'm not saying this is perfect, but this is one of the ways to figure out. Okay, low risk. So what did they do? They actually did this in another subset of group of patients, and they found the same database, the answer. They did the same thing in another database in Japan. And what did they find? They found out that it might help spare an MRSA therapy for only those patients who are likely to benefit. So you might be able to use the short score and at least use it only in those patients who will benefit. So first part of the story is short score. So we are doing all these things so that we avoid unnecessary antibiotics. Are you understanding? We are doing all this so that we avoid it, because we know the future is very bad for us. We don't want this future where our children falls down and we need to give them meropenem and tigoplanin. We don't want to do that, isn't it? We are all going to have children are going to grow up, and we don't want that situation like this. So similarly, that's why we want to avoid these unnecessary antibiotics. So short score. Got this answer first? Short score. Then the next thing is, let's look at throat swab and gram stain. Fantastic investigations, I feel, because you can do it very quickly. The simple thing you can do is doing a sputum gram stain. Don't just send a sputum gram stain and forget about it. Do the sputum gram stain, call the microbiologist and tell her what are you seeing. It will not take them more than 10 minutes. to see that. It will not take more than 10 minutes. So sputum gram stain you can do, which will give you whether it is gram positive or gram negative in the first place. And looking at that stain, they'll tell you whether it's cocci in chains or cocci in clusters. You know, clusters are staph, chains are streptococcus. It's simple to remember this. Okay, so you can actually do that. And throat swab. The throat swab, what happens is the throat swab. Throat swab is just taking a swab like how you do for RT-PCR. We just do a throat swab over here. When we do a throat swab, what they found was those patients who had pneumonia, 82% of them had it in their throat. That's how it's going inside. That's how it's going. The people who had pneumonia, that's the route. The route of going inside the lung, community acquired, is basically through the nose, throat, and then going down. So when they did throat swabs, they were able to get it. You understand? So just throat swab itself, along with the gram stain, will give you more data saying that if your short score is negative, throat swab is negative, and sputum culture gram stain is negative. In the first 3 hours, I can understand that no, I don't want to give this patient teicoplanin. Are you understanding? Or if I have all of these positive, I can start thinking maybe I need to start this patient on a drug like this. And that's what the sensitivity for throat swab is. This line is throat swab, trachea and throat. The more the line is towards this side, the more it is sensitive and specific. This line, so throat swab is line, the line is over here. Whereas nasal and all these things, the line is over here. You understand? That is why throat swab seems to be quite good in this case, right? So that means now I have two things that I can put in my sink. One is short score and the other is sputum and swab, right? We have finished these 3 things now, right? Now the other thing that comes is procalcitonin. Okay, now procalcitonin we all know is only used for de-escalation of an antibiotic. It is usually used only for de-escalation. So procalcitonin you can do and you can say it's less than 0.25, stop the antibiotic if the patient is clinically well. This is what we will say. However, we can use procalcitonin in this way also. We can actually do a procalcitonin because procalcitonin will not be as much elevated in atypical pneumonia, in legionella pneumonia, in viral pneumonia, in atelectasis and aspiration pneumonitis, which are all mimics of pneumonia, right? So it may not be elevated in these cases. It may not be. So it will not be characteristically elevated in these cases. But procalcitonin is expensive. Okay, you must remember procalcitonin is expensive. Though I am talking procalcitonin, it's an expensive investigation. But we know that in these cases, it may not be as much elevated as in MRSA bacteremia or bacterial infection, right? No, it's not as much elevated. So if I have procalcitonin that is very low, maybe this may not be MRSA pneumonia, right? Now, nothing can replace clinical judgment. And that is the end of the story. You need to actually have clinical judgment to understand what this is about. So how would you do this? So on day 1, okay, I will look at the MRSA short score, okay, and then if it is 0 to 1, let's not give any coverage. Let's not give any coverage with 0 to 1, okay. If it is 2 to 5, I need to use my clinical judgment to understand how severe, how sick, what is happening, does he have IV lines, does he have this, that, and all those things of what we discussed just now, all those things. 6 to 10, maybe I'll just start, I don't want to waste time. Okay, hours later I'll do a gram stain and throat culture, and based on that I'll take a call whether I need to keep the MRSA cover or take it off. Clear? This is probably the way I do. The oncology department has got this problem with febrile neutropenia. Okay, what happens in febrile neutropenia is we don't know what to do. Oncology department is supposed to be like the most good in infectious diseases and things like that because they deal with everything under the earth. Oncology, they deal with everything, so they're very good at infectious diseases. Okay, but oncology department can't take risks also because all these things does not come out very well in oncology. You can't actually see these things. Pneumonias and all you can't see, so it's very difficult to actually see. It takes time for them. So what do you do in febrile neutropenia? The moment you think febrile neutropenia, we think of gram-positive cover. This is what oncologists will think. Okay, so let's take this example of this hematological malignancy patient who comes in with chemotherapy. He has fever and is neutropenic. Ideal patient. Normally we see these patients in the ICU very often because it's febrile neutropenia. They cannot be admitted in the wards and they are probably going to be those that require the ICU. So the first thing the oncologist thinks is, I think she needs meropenem, teicoplanin, echinocandin and transfer her to ICU. This is what they normally think. Meropenem, teicoplanin, echinocandin and transfer her to ICU. This is what usually they think. But if you look at guidelines, they actually have a very different story. These are the guidelines in febrile neutropenia. So we call febrile neutropenia when the temperature, a single temperature is more than 38.33 degrees or there is 2 consecutive temperatures more than 38 degrees. With neutropenia, that is absolute neutrophil count of less than 0.5 to 10 to 9. Once it is there, then they are looking at MASCC criteria. There is something called MASCC criteria. When you febrile neutropenia, look at MASCC criteria and divide them into low risk and high risk. Okay, so when it is low risk, outpatient antibiotics, they don't even get the patient into the hospital very often. They keep them out only. IV antibiotics they require, they give responding criteria outpatient therapy over 2 to 4 to 24 hours. But here, what they are saying is, if there is high risk, this is where we are looking at clinically unstable medical comorbidities. In those cases, they are saying piperacillin, carbapenem, ceftazidime, or cefepime, any of these, and they are saying adjust the data, adjust the vancomycin only after you get cultures. They are not saying give it empirically. This is what guideline says. What does the guideline say? The guideline says if he was taking chemotherapy at home, and now this is community acquired, all these things. To take chemotherapy, and now he has developed a pneumonia. If he is coming from home, then most probably don't consider MRSA cover right away. The scenario is not same when the patient is here in the hospital. That is hospital acquired. That's different. This is a patient coming from home. In such a patient, you will probably give gram-negative cover and then send investigations to figure out whether there is going to be a requirement of vancomycin, linezolid, or any of those gram-positive covers. And you look at whether where the infection you think source of infection is. If it's below diaphragm, you start metro. Above diaphragm, you don't start metro. This is the thinking. And why do they think like this in abroad? Because they are generally not very virulent. MRSA is not very virulent. So they are adjusting vancomycin only based on culture reports. You're seeing that. It's adjusting all. So it's not always working to actually start empirically is what it is basically. It doesn't really work that way. That's why you require to culture them properly. Okay, what they found out over there in these patients of hematological malignancy is all MRSA isolates were susceptible to glycopeptides, first of all. And what they found, they seem to suggest that MRSHB in hematological patients is also with low morbidity and mortality rates. So even if you have MRSA, the mortality and morbidity is quite low. So you have some time when it comes to hematological malignancy is what it appears. Of course, you will use this data not to do it in your patient. This is abroad data. In my hospital, what is there? In my environment, what is there? That is what I am going to look at. My prevalence is high. Maybe no, I will not take this data. I will probably just give in. But if my prevalence is low, then I probably think, okay, the morbidity is not very high. We don't see patients with MRSA dying. You might see Klebsiella and Pseudomonas dying, but you won't see an MRSA dying. That's the difference. Because they have no mortality morbidity. So what does the Cochrane database say? What is the Cochrane collaboration, Cochrane collaboration, whenever you want to synthesize evidence and you want all the data to be put in one place and you want the answer, you will get a Cochrane database. You can go to a Cochrane database and they'll give you the answer. So when you put it into the Cochrane database of combination therapy, what they are saying is cancer patients with fever and suspected infection can be given single new generation beta-lactam antibiotic. Single therapy is efficacious. That means you don't require this combination of meropenem and vancomycin is what it says. Even in malignancies. Okay. Clear on this? Single therapy is always better. More is not better. In fact, there are data that comes from even from the EORTC, which is the organization that is responsible for all these granulocyte for cancers and things like that. EORTC. What they say, results do not support empirical addition of vancomycin to initial antibiotic therapy in cancer patients with fever and granulocytopenia. So you don't give. This is what even major guidelines are saying. Major guidelines in the US and the UK will say do not give this, wait for cultures to come, and you understand why now. You understand why? Because it's not very bad mortality, morbidity, but you do the cultures quickly. Okay, this is another neutropenia survey which actually says the same thing again. Look at the number of studies that they have looked at to get the systematic review. Okay, they have all these studies, and what they found was irrespective of giving or you don't need to do that because your diamond is right here. When the diamond crosses the line, it means there is no effect. Don't give this empirical antibiotic. So it doesn't require that vancomycin is what it appears. It does not change all-cause mortality. Clear on this? Clear? So all the studies put together also says the same thing, that it may not really help. Okay. Overall failure also doesn't change. Okay. Overall treatment failure also doesn't change even if you give empirical antibiotic. Currently available evidence of MRSA does not support the need for empirical glycopeptides initially or for persistent fever. Withholding is safe. This is what it appears. Okay, this is what it appears. So vancomycin is something anyways I am very skeptical in using because it's got resistance to staph. Now we know MRSA, visa, enterococcus also it has got some inducible. Enterococcus it's conditionally cidal, it's not always cidal on the enterococcus. IV drug abusers, they will have an infected lung, suspected CRBSI, if the patient has got a sinus sufficient infection with a malignancy, this is somewhere where I'll definitely give MRSA cover. Okay, if the patient is having any of these, if it's just a febrile neutropenia, no, but if the patient has got, say, a pneumonia, a real pneumonia that I'm seeing over there, presence of a total intravenous line that is there, got line over there, I'm having skin and soft tissue infections. These are things that are suspects, big suspects for MRSA. So I'll probably give the MRSA cover for these. Severe mucositis, another place from where MRSA can easily go through. So vancomycin is not recommended as a standard part of initial antibiotic regimen for fever and neutropenia, suspected catheter infection, SSTI, pneumonia, hemodynamic instability. These are the things where you probably think twice, unless there is a high risk or a previous colonization of MRSA. So the high risk of endemicity is what we have in our country. We just now discussed prevalence is 47%. So that way 27%. That's how endemicity comes up. That is a big problem with our country. So judiciously we have to do empirism. So mortality, even if it is adequate, if you are given adequate and not over adequate, the mortality is low. Remember this. It is not this way. Giving 2 is better than giving 1. If you give the right appropriate antibiotic, the mortality is lower. If he requires 1 antibiotic and you give 2, it's not that kuch hoega nahi. He will still have problems. He will have problems in the long run. And that is why this is what it is saying. In all group of patients, let it be ventilator associated pneumonia, let it be bloodstream infection, nosocomial or mixed MRSA, if you give extra antibiotics to a patient, there is going to be side effects, there is going to be mortality, morbidity, everything is going to be there. Okay, so you don't give an extra. That's why judicious empirism is what is required. Okay, it's only when you give appropriate antibiotic will the mortality be low. Infective endocarditis, another place where probably same thing, you have to give appropriate antibiotics. Okay, otherwise infection and mortality is very, very high. So this is something that came in long ago from the World Health Organization. A post-antibiotic era, that's where we are now, means that in effect an end to modern medicines, we know it. Okay, things as common as strep throat or a child scratch knee could once again kill. This we are in that situation now. This is a very important. We are in that situation now where simple infections can be quite dangerous. So having own data will help in the first place. So when you are actually treating your patients, you should know the data that is there in your country, in your hospital, in your area, in your region. You should know the data so that you know what to do. You have to use judicious use of labs. You can't just send sub pan culture भेज दिया और फिर देखो उसमें क्या आ रहा है. It doesn't work like that. It has to be syndromic. You have to understand what lab to send where, right? Scores are definitely good starting points. So if you know scores is good for you, you can start with those starting points at least so that those scores are something that will guide you. Okay. Algorithmic approach is very, very good. That's what I put an algorithm for you. And judiciously select patients who need gram-positive cover in febrile neutropenia, infective endocarditis, CAP and SSTI because they have got very high mortalities. These patients have got high mortalities and that's why it's very important to actually judiciously select. If you don't treat these patients, if they have MRSA, they will die. That's why you have to select them very, very carefully. Both the sides of the story is there. Okay? Any further questions on MRSA?
So just going back to the case you told.
So in that case, what do I now? Let's go back to the case. What happened in that case?
So
70-year-old dementia female. What is the short score there?
2.
70-year-old dementia female. So and gram-positive cocaine clusters. Okay. So gram-stain is positive. Then procalcitonin. I have not put it. So maybe if I did the procalcitonin in that case, maybe. But patients clinically improving, less likely to be MRSA. So I would not probably give anything there. You understand? That's how we probably do it. So,